questioning.
Well, thank you very much, Mr. Chairman, and thank you to our witnesses. This is a really critically important topic, and we very much appreciate you contributing your expertise. Ms. Van Meter, I'd like to start with you. I was really interested in the part of your testimony where you were talking about improving Medicare's payment structure for clinical labs and the way that doing that could help foster innovation for diagnosis. I've long been interested in the application of artificial intelligence to that particular space. I chaired the House Task Force on AI last Congress, and this is, we always said we had a whole chapter in our task force report just on healthcare, because we really think that of all of the applications of AI, really the low-hanging fruit, the way it can most immediately contribute to the well-being of people is through the healthcare space, and certainly through the lab space as well. So can you tell us a little bit more about how AI is being utilized in the diagnostic lab industry?
Yeah, thank you, Congressman. Really in two key facets. One is to improve and create efficiencies within the operation of the laboratory. And that could also move into the business side with administration, right, as we have to deal with huge volumes of claims and the like. But when it comes to clinical care, particularly in the space of genomics, leveraging AI tools to look at enormous data sets that can't be consumed by a human on its own allows us to open up discoveries, both in terms of improving personalized diagnostics, but then driving therapies on an individualized basis for patients. So really there is tremendous promise that exists today with AI tools in diagnostics.
Sure. Well, it's interesting that that mirrors the use of AI and other spaces in the healthcare industry where initially we're seeing the biggest returns in terms of improving administration. I mean, for example, physicians, automated note-taking is the number one way that they're using AI right now, which is not what you would think of when you first think of the application of AI to healthcare. But all of those other concomitant uses for AI are coming, and we hope they come to the diagnostic lab space as well. Mr. Ryan, I was really interested in the part of your testimony when you said that the reimbursement rates for liquid oxygen are far below supplier costs. Could you talk a little bit more about that gap between the CMS reimbursement rates and the actual supplier expenses? Because I'm very interested in that.
Yeah, like we said earlier, thank you, Congressman, for the question, that Medicare's reimbursement for oxygen is based on, all product categories. And different product categories have different cost points to them. Liquid oxygen is one of the most expensive product categories due to the nature of the FDA oversight and the infrastructure that the company must build to provide liquid oxygen. Back before competitive bidding, Medicare would pay per pound for liquid oxygen. My company probably had, when I was in business, before competitive bidding, 30 to 40% of the patients would be on liquid oxygen. It was extremely convenient for the patient. They could ambulate, get out and about. You could fill from your liquid canister, a portable canister, and go out and about. You didn't have to be limited by the number of hours or limited hours in a gaseous oxygen tank. But the reimbursement changed drastically, and then because of that, everybody, like my company, I didn't survive the competitive bidding port, but they got out of the business. And now technology has evolved, so you do have things like portable oxygen concentrators, where you can get lower flow oxygen from a portable concentrated device that provides a battery, and the battery is then your lifeblood. Do I have enough batteries to make sure I can go out and about and get my chores done? But there is a subset of patients who require a higher liter flow, and that higher liter flow in today's technology is not able to be accomplished with a POC, and it can be accomplished with a gaseous tank, but the amount of oxygen that you would need to use, that gaseous tank would empty out every 30 minutes. I had said earlier that 1 cubic foot of liquid oxygen expands to 860 cubic foot of gaseous oxygen. So old technology, but very, very useful for a subset of patients that has been completely taken off the market due to the reimbursement structure.
Right. Well, I think sometimes we forget as we negotiate these reimbursement rates that the end goal is not just greater efficiencies for the taxpayer. We're trying to strike this balance between providing world-class healthcare with positive healthcare outcomes, at the lowest cost to taxpayers. And achieving that balance can be tricky, but That's why all of you being here today is so important. So thanks very much for your testimony. I yield back.